Okay, good morning, everyone. It's 11:02. We're just going to give it 1 more minute longer for a few more people to join, and then we'll make a start on the geospatial presentation. Hi, Nick. How you doing?
Yeah, not too bad.
We're just giving it 1 more minute longer and letting numbers tick up,
Cool.
and then we're going to run through the presentation. 2 presentations today, and then the tool, and then a lot of Q&A, hopefully, as well. Okay, it's 11:03. I'm going to make a start. I'm sure we'll have people joining throughout the call. My name's Paul Carroll. I'm a senior data scientist on the digital analytics and research team. I'm sharing my screen with you now for a piece of work that we started back in 2022 in March. I'm just going to move to presentation mode. Okay. Today I'd like to talk to you about a project that took place in March last year. The aim was really to create a geospatial tool using Python and to solve a plethora of, I guess, NHS use cases. For example, if you're looking to cite a new GP practice, what do you need to take into account? What do retail do when McDonald's, for example, are looking to cite a new location? So identify existing sites, substitutes, catchment areas, and working out access, time for travel for patients or customers. Last year, we were given a week, myself and Mattia Ficcarelli, one of our software developers, to take this project as far forward as possible within this time. Could we do this using only open source tools and freely available data? So initially, we started by scoping and seeing what was out there. We didn't want to reproduce an existing piece of work. There's no value in us wasting NHS time trying to rebuild something that's already been better done. I'm not sure if you're familiar with Shape Atlas, but this is a really good piece of software built by, I think, at HSE at the time and now run by Department of Health and Social Care. It stands for the Strategic Health Asset Planning and Evaluation Tool. It's a brilliant app and a brilliant piece of software, but it's static. And if you want to put your data into it to find out where you could cite a new location, you have to send your data to the Shape team, which means crossing IG boundaries. Part of my job within the digital analytics and research team is working with PhD students that we sometimes embed in different trusts. And the only way we've ever been able to access trust data, as I'm sure a lot of you are familiar with, is within that IG boundary. So we either are sent a laptop or a portal login to be able to do that. Shape Atlas is ruled out for that type of reason. So our differential here was trying to produce a software piece that, or piece of code that anyone could run and adapt to their own needs. As I said, there's a lot of finished products out there, but there's a huge amount of differing needs for tools like this within the NHS. So Mattia initially focused on 2 different areas. One he'd worked on previously, GP practices, and he wanted to see if he could develop this a bit further, taking into account travel times to GP practices, in this case, specifically walking times. So Mattia initially used the NHS GP practices data table that's available on NHS Digital called Epica, the Epica CSV file, and the OSMNX library in Python. He then also decided to look at different means of transport and identifying differences in times of travel dependent on the time of day. I tried to build on Mattia's work and took his work as a springboard and tried to take that development further. Could I initially identify possible gaps in services using the travel time code Mattia had deployed? And then could I try and combine modes of transport with the aim of providing the end user with shortest route functionality? Practically, this piece of work involved a few problems. So Mattia looked at running this on Cambridge, which is a smaller town, not many OSMNX nodes and edges, if you're familiar with the NetworkX library. If you think of somewhere like London or number of GP practices or Cornwall or even like North Yorkshire, there's a huge amount of nodes and edges, which is how you build a NetworkX graph. We just focused on a small area initially. Mattia worked first and I followed on from his work. The main part of this was that technical aspects of this work had to be reusable and open source and non-proprietary. So we used GeoPandas libraries, GeoJSON files, isochrones, Folium, and we harnessed the ability to really turn the geodata frame from isochrone polygons into GeoJSON files. The plan was to go away, work separately, and then bring the work together later on. This was the initial piece of work that Mattia took forward. So I'll run through the 4 areas we took this forward. Mattia looked at Cambridge and he looked at the postcode CB1 to CB5, which is the Folium library picture that you see on the left. It's an interactive map. I won't show the interactivity here. I will do when we come to the Streamlit tool a bit later on. But this has your zoom functions on the left and it has a filter function on the right. The GP practices are on the right-hand side here and the postcode's highlighted on the left. If you add the OSMNX nodes and edges for Cambridge, you can see you're starting to get a picture of what the town looks like, where the streets are, where the junctions are. And on the right are the foundations for isochrone polygons. We've colored these in red for 5 minute, orange for 10, and yellow for 20. If you start combining these pieces of work, this is what you start to get to. So the isochrone polygons on a folio map are on the left, and the interactivity, as I mentioned, is what you see with the GP practices highlighted in the center of these polygons on the right, with 5, 10 minutes, and 20 minutes as the filters that you can turn off or on within this map. So whilst OSMNX is quite useful, there are certain areas where it does fall down. It assumes a free flow travel time, or it assumes a fixed travel time that you can hard code in there. In major cities such as London, free flow speed is rarely, if ever, achieved, especially during rush hour. So in this section of the project, Mattia took travel times from Uber movement data, combined this with OSMNX to estimate travel times between GP practices in St John's Wood and St Thomas's Hospital. The left picture shows the OSMNX rendering of some areas of central London, and the right, the free flow in the light blue, and the blue is the Uber weighted travel time in the dark blue. Part 3 of the project was where my area came in. I was conducting research for this area of the project. I live in the Midlands. My in-laws live in Lincolnshire. Some areas of it are quite sparsely populated. I wanted to see what you could do with combining first response level services. So A&E is what you see on the right, 24-hour A&E services, and then what might be your next level of services. This isn't something that's easily findable, but it is searchable on NHS websites if you look at one or the other, but you can't combine the two very easily. So I wanted to see what can we do with this layering. The 4 sites you're seeing are the 4 24-hour A&E sites in Lincolnshire. I think it's Grimsby, Lincoln, Boston. I forget the 4th. Someone from Lincolnshire will probably kill me for that. Apologies. Trying to solve the problem. This is the code that we used. We used an API call. I had the hospital data set, again, from NHS Digital. A little investigation showed me that those 4 24-hour A&E sites were in the largest populated towns and cities. So using an API key for a Google Map search, we wrote some code that would output whatever you wanted to search for, but give you the results with longitude and latitude. So this search here, this is just the code. What this produced when I searched for urgent care centres, the next level down in Lincolnshire, produced what you see at the bottom here. So you have Lincoln Urgent Treatment Care Centre and the longitude and latitude. If you combine the two, what you're able to see is the map on the left. So you get this layering we were talking about before. The blue dots are the urgent care centres, the green markers are the A&E centres. And if you add travel times, which we used from Mattia's coding before, on the right-hand side, you're starting to see where this map and the layers can be put together to give you an idea about service coverage. With the isochrones fully rendered on the left, you can see the 10, 20 and 30-minute driving times. And this is done at a more rural capacity of 40 miles an hour or 60 k's per hour. But this does allow you to see on the right-hand side where you may have a lack of coverage for 24-hour emergency care and where there may be a need for potentially having a helicopter response or some other type of response if those A&E centres are all you have to get to and the urgent care centres are closed. Part 4 of this part of the project was looking at combining different modes of transport within a populous area, in this case, London. So what you're looking at on the left here is the tube overground map, and on the right-hand side, in the middle picture, it's rendered in OSMNX. And on the right, as you can imagine in London, there's a plethora of GP practices. The aim with this part of the project was to calculate multiple shortest route functionality, but combining walking and tube. And this, as I said, this was a presentation I delivered last year in NHS PyCom. The presentation really brought this project back to life. We were contacted, we had Google Health lent us 2 of their engineers who selected this project as something we could take forward. And that was a 20% charity time that they give up to work with NHS England through the PyCom organisation through that conference. And myself and a few other members of our digital analytics team were asked to see if we could take this piece of work forward into something that we could actually use and something we could actually build something else on. And when I say something else, it's become what we called Medical Map, which is this Geospatial Streamlit app. Bringing all the background together from NHS PICOM, that presentation led to obviously Google Health being involved, but it also led to different areas of the NHS getting in touch with us. So we had feedback from the Net Zero Travel and Transport team. We had feedback from the COVID team, the COVID site placement team, for where they would put, at the time, COVID vans to go out, or a COVID site to be placed for different parts of the population to come and visit, were those not in GP practices or in hospitals. We also had Bart's oncology department get in touch. And at the time I was working with PhDs, students placed in Essex, and Northeast Essex and Suffolk Trust, the SDEF Trust. They mentioned the need for multiple shortest route functionality. So somewhere where they could have their patient list uploaded into a tool or into a Jupyter notebook, and they could look at where they could take potentially a blood test van or a diabetes test van out to reduce appointment cancellations, which is an area of the NHS that was costing them a lot of money. I know there's research out there saying, should we be paying for taxis for patients to come in? Well, also, can you take the appointment, like donating blood? Can you take the appointment centre to the patients? With the help, we would never have got this done without these two amazing Google Health engineers, one of which is on the call today. Thank you, Nick. And the team, Ollie Jones and myself and Mohammed Faish from our team, as well as Mary Emmanuel. Five of us worked together trying to take this forward. Journey optimization was one of the big things that really came out of a lot of the feedback from the conference. So in a classic kind of computer science problem, it's the traveling salesman algorithm, the traveling salesman type problem. And I'm sure every trust across the country has logistic issues with things like blood deliveries or district nurse visits, or even simple things like, how do you drop off patients from an ambulance drop off when they can't take themselves home? How do you organize the route that they go on? As we scratched the surface with this, we found out that most of these services are paid for, they're commercial, because the traveling salesman problem isn't an easily solved problem. The second area we came to with this was community health and staff modal shift. So as I said, appointment cancellations earlier, community blood tests or diabetes test vans going out into the population. There was also an area of NHS Net Zero Travel and Transport mentioned was sustainability. So providing an evidence base for emissions reduction. And this meant things like mapping staff homework locations and routes to understand what travel options are available. And this was quite useful for certain trusts, we were told, when it comes to them talking with local authorities as what bus routes to lay on, or when they need public transport for certain areas, but also things like allocating parking permits to those staff members who don't have any other way of getting in. All in all, we focused on 6 use cases, and we tried to pare these down to 3 different types of algorithm solving problems within coding. The first was route optimization, as I mentioned, so your traveling salesman problem. The second was multiple shortest routes. So you put in a target address and you see how far your list of patients or your list of staff work from the point that you're trying to measure. And the third was site scoring. So something like retail. What population coverage do we have within 1, 2, 3, 4, 5 miles? And what's the distance to travel? How do we do walking distance if you want to look at a new GP practice for patients over the age of 70, for example? And this was to solve 2 problems, which I've kind of alluded to before. The first was cost. There are commercial solutions, and the benefit of commercial solutions out there is they do this very well. They also can be contracted to make sure that your data never leaves the trust unless it's on a contract obligation. So there's protection there. But they do cost, and that's the negative. Anywhere from our research suggested between 40k and £200,000 per trust per year. I'm sure people on this call can probably tell me a lot more information about that. The second issue is data and IG. The free solutions we found out there for some of these problems required data to be sent to them. So Shape Atlas, which is free for NHS workers. But your data quite often in trusts cannot leave your area. So our repo and what we've built can be forked and cloned by any NHS employee within the trust, with the aim of being adapted to your own data and being able to be tuned to what you need it to do within that trust, and you can have a page for each area of this. So without further ado, that brings me to the end of the presentation. I want to spin up the tool and show you how this works live. So just before I do, there are 4 different repos I'm going to be showing you here that the work has all come from that you've seen in the presentation just now. All of these are areas that we've worked on within our trust. The last one I'm going to add to you and show you is a geospatial professor who we took the idea from for the code, We didn't copy exactly what he's done because he works on a different area, but I'm just going to share these repos with you within the chat here so that you can take these at your leisure. There's workbooks in there for some of the repos. Please have a read through. It will give you far more information than we've just run through in a very quick presentation. But we've got the run-throughs, we've got the repos, there's workbooks, as I said. There's also another piece of work here, which I think someone mentioned in the question, which is to do with public health data. So this is a ESNEFT analysis on broad level diabetes inequalities. And this is about adding choropleth maps in for things like LSOAs and postcode matching. If you read through it, you can see some of the work that one of our students did before here. None of this has proprietary information in, it's all using open source data. So please take a look at your leisure. I'm going to try and spin up the app that we built. Let's do this live and hope that nothing goes wrong with the live bugs that you get with these things. So the app we built is basically something that you can clone and you can download yourself. You need to set up an environment. And once you've set up your environment, you'll need to install the requirements that are in. If you follow the README within the PyCom NHS time of travel repo that I've just shared with you, this one line of code here, Streamlit run Streamlit app.py, will load the Streamlit app that we've built to tackle those 3 use cases. It really is that simple. Okay, and once the Streamlit app loads, this is what it looks like. This is our introduction page, and we have the 3 pages listed down here on the left. As I said before, this is a concept piece of work. It does solve some problems that are straight out of the box, but really the way we envisage this being used is you could fork the repo, take it into your trust, adapt it to your data, test it yourself to make sure you're happy with its results, even test it against your existing geospatial solutions, and you can build as many pages as you want down the left-hand side. The traveling salesman problem is what is the route optimizer. So the app comes preloaded with the hospital dataset, which is NHS Digital's list of hospitals for, I think, NHS England and Wales. If you select a town from here, we'll use Cambridge. The data frame will filter from the full list, which if I click on here, you can see what the data frame looks like. It's just the list of the names and the longitudes and latitudes. If we select Cambridge, it should filter to all the hospitals that are available in the Cambridge area. It should be these 8. We've got the first hospital highlighted as a start address here, but you can change that as you wish within the list of preloaded hospitals. I've selected the network type as drive and I'll click submit. And hopefully within 10 or 20 seconds, you'll see the route optimizer load with a suggestion for how you can best get around Cambridge in the list of these hospitals. And here's the results. So number 1 is in Nuffield Hospital, which was number 1 on the list here. 30 New Road, I think, is the Spire Hospital, Spire Cambridge. And then you've got the rest of the hospitals in the list, 3, 4, 5, 6, 7, and 8. Adam Brooks is Hills Road. I think the Royal Papworth is in there as well, and the Rosie Hospital on Robinson Way. That's how it works for the list of preloaded hospitals. The data frame below gives you your from and to. It also gives you the distances and your total distances in miles. We've added in hard-coded things like walking time, peak driving time, off-peak driving time, and cycle time. But again, those hard-coded numbers can be changed depending on where you want this to work within your trust. I'm just going to show you the malleability of this tool, because if you change it to something like Royal Papworth and you want to recalculate, and this is using the preloaded list, it's really, really easy. It just loads a different order for them, calculates it. I think, where's number 1 gone? 1, 2, 3 are here, 4, 5, 6, 7, and then it takes you to 8. This isn't the way we envisaged this tool being used. So there is a browse files section here too, and this takes you to a template section. I'll show you what the template looks like. So if you are a district nurse, for example, or if you are a logistics team running a set of addresses for a district nurse or ambulance drop-offs, this is what the address template looks like. You just need to put in the name and the address. I put 4 in here for the ESNEFT area where I did a presentation with a little while ago. 3 of these are hospitals and 1 is a random address because, as you'd expect, it could be addresses for patients. It could be anything you need. And I wanted to cover areas that aren't just one town, as I've just shown you. So these are the 4 in the address template split. If you click on Browse Files, it brings you to a searcher within your own computer. If you upload this, you now see that Excel template dropped into here. So we have the 4 addresses. Again, you can select your start address from the preloaded list that you've just done. If you click Submit, we'll start to see this work for a list of addresses that you could do or change on a daily basis or bi-daily basis if you're doing morning drop-offs or afternoon drop-offs for something like ambulance patient drop-offs. And here we go. The map generates, and you have Stowmarket, 2 hospitals in close to each other in Ipswich, followed by the 4th hospital in Turner Road, Colchester, in Essex. And again, you can just change the order if you needed to, or you could put in your own start address. Say if it was the home address for where a district nurse may start out from, you could add that in as well and write that in, and then the map will regenerate. Generally, this doesn't take too long to load. I wanted to show you a little bit about how this is working. The way we built this is, and the way we envisioned it being used is, if you're sitting in a trust running the same area on a daily basis, you may load Cornwall once, or you may load your ICB area once with a certain radius around where you're looking for your drop-offs. That call is a nominatim API call that goes out and brings a network X map back, and it's cached. So I think within here, you may be able to see where there's been a call within my laptop for producing the cached map instead of making a second, here we go, retrieve response from cache file, instead of making a second call for the API. So if you are in a big area like Cornwall or North Yorkshire, that first call may take 30 seconds, a minute or 2, but the second time you upload data onto this, the background map, the network X map, is retrieved from your API, from your cache, instead of going out as an API call. So it makes the program run a lot faster. I've only done this with 4 addresses here. To be honest, the way we envisioned this working was between 8 and 10 maximum. With the traveling salesman problem, we've used 2 algorithms here to calculate what are the optimal routes and what's the shortest route between those 2 algorithms. If you're getting to think things like 10 calculations and 10 permutations, you're talking about 3.6 million calculations. At 12, it becomes 480 million. But there is a sweet spot, and we didn't envisage an NHS route optimizer being used for somewhere like 15 or 16 drop-offs, simply because there wouldn't be enough time during a day for a district nurse to visit that many patients and spend quality time with them. Likewise, ambulance drop-offs would probably be 4 or 5 or maybe 8 or 10 at most. So once you do start to get past 10 or 12, your computer will slow down. But we've designed this to be used with, I'm on a work laptop here, and we want people to use this on their work laptops and it not fall over and not crash. The multiple shortest route functionality. So let me refresh the page and drop the data I just loaded. Again, this comes preloaded with hospital data. I'll select Woking here. It's one we quite like to do for this, which gives you a list of 5 hospitals. I'll put in Pizza Express Woking as a vaguely familiar place that most people have heard of by now. And we can load, and you can look at the multiple shortest routes that are generated from that central target address to all of these different hospitals. If I zoom out slightly on the map, we've made the map in black and white so you can more clearly see color-coded routes. You click on the folio map, you've got a level of interactivity here, which gives you enough detail, and this can be customized as you wish. That's the center point that I put in for target address. You have your Nuffield Health, Woking Community Hospital, Priory Hospital and Chobham, and then there's 2 sat behind here. I think if I zoom in, you can see a bit more clearly. Yeah, one there, Signet, and they're both the Signet Hospital with slightly different address, so it must be different departments. The benefit of this style of map here is you've got this interactivity, which I talked about a little bit earlier. You can turn these routes off if you want to examine them more. One will always stay highlighted, but the rest of them will stay on and off, as you see, kind of appearing behind me there. This can be done for, if we looked at Ipswich or a different town, you could do the same thing. You could load them and you'd have multiple shortest routes. You'd also have the hospitals, the addresses, or whatever address you've uploaded. You'd have the distances in miles and the hard-coded walking times, peak driving times, or off-peak driving times. We envisaged this being adapted to maybe adding things like bus timetables in, and you could look at public transport routes to certain areas. The specific ask for this one came from the ESNEF Trust, whereby patient cancellations was becoming a problem. And one of the analysts there wanted to upload patient data straight from his laptop and just use it. If you are doing that in the browse files here, nothing's leaving your laptop. This is just your data on your address template, and it will go into the tool that you're running. We're not hosting this. So this is something that you're spinning up and running. It means you're not going to have that IG problem. And that was the real benefit of us doing this tool this way for that specific ask. The max coverage location was the final tool we've built, but this is really a proof of concept tool here. I'm going to show you for Adam Brooks at the center address here, because what we really wanted to do was say, Well, if you do have a van that's going to go out and you want to know how much of your population is being covered by this, how can you do that? Now, we took a very simplistic approach of just doing a target address, 1 mile radius here, which you can go up or down. I'll show you going up a bit higher later on, but also walking speeds. And we've defaulted to 4 different ones that you can pick from a drop down here. What could be added into somewhere like this is if you put GP practices in, like in the original project that Mattia and I did, you could look at complements or substitutes or where you have a gap in coverage. What you see on the map here is a list of LSOAs. So the LSOAs have been added as a filter layer here. If you hover over each of them, you can see the population for each of those LSOAs. The red radius, the red circumference is the radius that you've selected for radius in miles. And the center point is Adam Brooks, 24 Hills Road in Cambridge. The blue LSOAs are ones where the centroid point of that LSOA is within that radius. We wanted to show ones where the centroid point is outside, but there is some coverage for that population area here as well. Beneath, we've got 2 summary statistics, but again, this is just a proof of concept. You can adapt this to how you need it to be used. The average weighted travel time here for walking at 3 miles an hour is 19 minutes, and the level of population you've covered here is 38,000. If we change this to being 5, and we'll do driving rural, maybe do driving off-peak urban for a bit of a mix of Cambridge and non-Cambridge, you can see where this can be adapted to see how much more population you would cover. In somewhere like SNF Trust, we've got 2 fairly small urban centres, Ipswich and Colchester. You've got a lot of rural population. So if they were to send a blood van out and you wanted to check how much your population is being covered but not use specific patient data, this is the type of tool that could be quite useful. Okay, so here we've got a 5 mile radius, 10 miles diameter, circumference running around the edge, and you've got a different level now of population coverage. The average rated travel time at a driving speed of 20 miles an hour is 8 minutes, and you've got a population covered of just under 200,000. Again, like I say, this is something that we envisage could be coded, forked, coded, data added, and changed within your own organization. That brings me to the end of our live run through. So I've taken a bit longer than I planned on doing there, but I'd love to go to the floor and have some questions on geospatial tools, if that's all right. Victoria, what's the best way to go through questions on this now?
Super, really interesting, Paul. No, I really enjoyed that presentation. Thank you. Yeah, sure. If anybody wants to pop a question in the chat, or seeing as though we're not a massive group today, we could do hands up as well. So feel free to raise your hand if you've got a question, or just kind of any reflections, really. Would be great to hear. We've got Neha. Hi, Neha.
Hi, Victoria. Hi, Paul. Thank you so much for the great presentation. It was really a hard work and, to do all the computations and everything and to produce it on Streamlit. My question is just like, what is the way forward? Like you have, presented it on local hosts. So what are the things that you are planning to do in future? Like, are you planning to host it somewhere, and what are the plans, like where you can host it, depending upon what are the NHS infrastructure is in their place?
Sure. At the moment, the way we plan to roll this out is we're at alpha stage now, so we're having users test this and take it forward. We don't ever want to host it, to be honest, because the way we envisage it being used is, say SNF Trust or any NHS trust around the country will fork the repo, use the repo in their own laptop in their own trust, and they'll adapt it to where they need it to use. So we can help them with that code to get set up, but we're not going to support it from a software engineering point. The main reason is if we go down the hosting route, we're in the same category as Shape Atlas or other tools where you have to send your data to that server. And that is something that we don't think can be, IG restrictions are quite tough to get around. So it's easier for us to bring the software and the code to the data. And that's why we've taken this type of approach. We've got a GitHub repo out there, which we've shared freely with you. There's also workbooks in there, so you can see our workings and how we've gone through these types of calculations and solved the issues. But there's also an issues part. So if people want to get in touch and use the code and say this doesn't work, or we'd like it to do this, we can take requests. We can put them forward to our team and see if we can either try and solve smaller issues ourselves, or if it's a bigger piece of work, put it through our kind of hierarchy of work and see if we can allocate some resource to it. But really, we envisage it being used by coders within a trust to support that logistics team.
Thank you. No, it's also because I know like all the data people can really work with it and can learn from it definitely. But I was just like curious because where you mentioned like if nurses or midwives have to use this particular app for them because they are not coders, they will have difficulty to access the information. So probably there could be a way around that. This information could be passed on to them as well.
Yeah, I think from what I've gained from speaking to different trusts is they have a logistics team or an analyst who produces their list of logistics outputs. So, if it's a district nurse drop off, then they're getting emailed that list of patients to visit that day. Well, at the source where the trust is paying for that contract, maybe they could try out this tool and see if it works just as well. And then that coder can just run, I showed you how easy it is to upload this and also to get it running. If you can just install the environment and install the requirements for it, it can be, there's no reason this couldn't be used within that trust to do the same style of work. And that's what we'd hope, is that it wouldn't be a district nurse running this themselves, because that's not how they work now. We don't want to change the ways of working that way. We just want logistics teams or other areas where analysts are working with things similar to this to be able to use it and maybe replace that commercial opportunity. I mean, who knows?
Yeah. No, thank you. Thank you for your presentation. It was great. Thank you so much.
No problem. Thank you.
We've got Andrew's hand up. Andrew, do you want to come off mute and feel free to ask your question?
But first of all, hi, I'm Andy. I'm the data science lead for NHS Dorset. Can I just say this is probably the best, most fantastic tool I've seen presented that I could literally lift, shift, adapt a bit and implement across the ICS, which is exactly what we're looking for in terms of, as a small team, we can't do it all. And to have something like this available and to be able to implement it locally, I can already see the possibilities for clinical service reviews and placing locations and the whole neighbourhood work and have we got everything in the right location. Massive potential for that. So first of all, thank you to you and the team. And already my mind was then going, right, can we link in traffic data? Can we make it operational? All these possibilities. So I think it's just probably going to go away and digest. But yeah, very much already thinking, have the team got a week or two in the next month to make this live and make this happen, because this is possibly a game changer for some services.
Yeah, please definitely if there are requirements, like I say, out there that you think may be useful, let us know if they're just tweaks and we can help you with that. If they're bigger things like adding a new page in and you aren't comfortable fully doing it, you can raise that request and we can speak to either work together or put the request into our team to see if we can build a fourth or fifth page. And see, the way we want this to work really is if you did have your own version of it, obviously that'd be private with your own data, but if it's reproducible code, like the reproduce analytical pipelines, like the 3 pages I showed you now, I'm sure if your trust is doing this, every other trust is going to need similar styles of work as well. So we'd love to be able to share this around the NHS. But please get in touch if there's anything you need from this.
Yeah, definitely will do. I might be dropping you an email in the next few days.
Great. Thank you, Andy.
Thanks.
Amazing feedback for you, Paul and team. You've got no more hands up, but you've got Andrew in the chat just saying great potential for workforce planning, useful to understand time to travel to aid staff retention. And also, we've just got another bit saying could be possibly self-hosted to create local accessibility across staff groups. And then we've got Liam posting in the chat. So if people could read that and consider that as well, that would be great.
Yeah, I'd like to point you to within the repos that I've shared within the chat, there are some readmes in there, and there's quite a long index.md in I think most of the repos, where you should be able to read a walkthrough for how we got to where we're going, how the code works, and what part you need to do for each part. It will take you through a step-by-step and show you. I think there's also some pictures in there in case you don't. So you don't need to spin up the app to show people within your trust or to take it somewhere. You can just show the repo. There's also a slide pack which will be put together for this, which we'll be adding into the repo shortly. So that can be presented to non-technical users and just raised up on PowerPoint from the repo. So if you do want to clone it, please go ahead and use those to show what could be done. I've also pointed the last repo, sorry, the one that ends GIS WQS, is the 9-page tool that was built by a geospatial professor at the University of Tennessee, which is where we got the inspiration for how to go about this style of work. He's tackled a different set of problems with geospatial work, mainly to do with things like forest fires and housing data in the US. But we used the same format of Streamlit, and it was part of why we used Streamlit to go down this route, where you can have an index of pages on the left and just change what you want each page to do. There may be options within that could be integrated within this, but within the repo you will see the framework for how we built the Streamlit app, and also the workbooks which take you through how the code works behind the scenes. So if that doesn't cover everything, or if you just have any suggestion on that, please let me know as well. We're in the feedback stage now and are trying to move the app from being alpha and development to being something that people could really use, or could at least adapt and test within their own environment.
Brilliant, thank you. Just we're in the final minutes. Oh, Lee wants to come. Feel free to come off mute, Lee.
Oh, hi. Yeah, thank you. Thanks again for the presentation. Absolutely brilliant. And yeah, I can see me using this here in the Southwest Ambulance Service. I just want to ask around performance. Did you say you were using Network X package to perform like shortest path distance calculations, etc.? Have you done any performance testing on other graph packages? I'm thinking certainly we've used iGraph before, and that's orders of magnitude faster than Network X. And I think there's another, is it Graph Tool or something like that as well? Either way, there's a few other packages out there that maybe if you haven't looked at the performance on those could really help scale things up possibly.
We have done some performance testing, but we've only done it for Network X. We haven't done it for other potential software solutions. The reason we stayed focused on Network X was really the biggest areas we looked at trying to load were places like Cornwall or cross-boundary ICSs, so Suffolk and Essex, for example. We really wanted to focus around the ICS level. We didn't want to run, north of England, for example. We wanted to focus on how it could really be used. So the longest we found performance issues with was the first time we loaded, for example, the Network X map of Cornwall. And it took about 3 or 4 minutes. It didn't take too long, but it caches that map. So the second time you run any data on top of it, it just pulls it from your cache. So the performance issues almost go away the second time you use or run an area, especially if you don't clear the cache. So we didn't think that was a problem, which led us to not exploring other options for this. There is a problem if you try and run this for north of England or the whole of the southeast. Then yes, if you're including London and southeast, it may fall over for a huge area, but we tried to focus around the style of user we thought might want to use this.
Yeah, okay, thanks. Yeah,
it doesn't mean it couldn't be replaced though. You're right.
No, okay. Yeah, I could, because the code's there, I'm guessing we could easily plug in other packages and then I could use. So for me, I'm interested in the southwest because our ambulance service covers all of that area. So yeah, okay, brilliant.
But again, there, if you loaded Devon and Cornwall or had a center point and it goes out for the whole of your ICS, the second time you run that map, it will just pull that Network X map from your cache. So you won't have to have an API call and it won't take a long time to build it. So that's how the problem gets circumnavigated in a way.
Yeah. Okay. Thanks, Paul.
Great. Thanks, Lee.
Great. And just one last one that we can take in the final minutes. In the chat, are there any plans in the future to add supporting functionality to visualize socioeconomic data or wider determinants of health overlaid onto this tool?
I think we're at the point where requests like this, if it's something that would be used, could probably come to us. We just showed the first 2 pieces of work here are ones that really could be shown out of the box. The traveling salesman problem is an algorithm, so that can be run directly on performance. We selected 2 algorithms here and didn't go down the route of simulated annealing or other styles of algorithms. Likewise, multiple shortest route is just a route calculation using a Network X map. But for the third piece, which is where we're using LSOA data, yes, this could be broken down, and we could look at demographics within that. You could look at some of the areas that Shape Atlas does already with, disease prevalence in certain areas or education level. And that's been partly done by Stephen with one of my PhD students within, I think it's the Diabetes Inequalities repo I showed you, where he worked with diabetes and inequalities data from SNF Trust. It could definitely be done, but we wanted to stop at this for a concept piece of work now without having any direct user to tune this piece of work to. So if there is a specific use case, definitely get in touch and let us know what you think you want it to do, and we could have a discussion about that.
Super, thanks, Paul. I think you might be getting a few emails over the coming days as people have time to digest this even further and follow the
hope so.
links you've posted in the chat. So yeah, that offer's there for people to reach out to you. Hopefully your email is available in the invite, but if you probably just want to pop it in the chat for ease, that might be great. Perfect. Well, massive thank you to you, Paul, for presenting, and to you and the wider team for great work. I think praise indeed from the group, and thanks everyone for attending today. Really great session. Liam has posted in the chat about a community of practice that is looking to be spun up under Analyst X, so do take a look at that. And I will be posting in the chat the next event coming up through the Pop Health Data and Analytics Centre of Excellence. So thanks again, Paul. Thank you, everyone. Have a good rest of your day.
Thanks, guys. Been a pleasure.
Thanks, everyone.
Thanks, Paul. Thanks, everyone.
Thank you.
Thank you, Paul.